Debby is a nurse consultant in gynaecology at Guy's and St Thomas's. Her current caseload is a one-stop outpatient procedure clinic, menopause clinic, and a joint clinic in the Haemophilia Centre for Women with Bleeding Disorders and Gynae Problems. She is a non-medical prescriber, a menopause specialist, and a menopause trainer. And I would like to personally say that Debby is also someone who answers GP queries, and she gets quite a lot from me. And I'm sure she'd be far too polite today to say, oh my gosh, it's not her, is it?
Thank you very much, Audrey. And I always look forward to getting queries. We get quite a lot, as you said. I am going to talk about menopause. Now, I could talk about menopause for a very long time. So I've tried to keep this as brief as I can, so that we've got time for questions and things. So hopefully I've got a few slides. So I'm just going to give a little bit of an overview. So I'm going to talk about what the menopause is. I'm going to talk about what you can do just briefly in terms of diet and lifestyle, talk about alternatives, so that's prescribed and non-prescribed, a bit about complementary therapies for the evidence, and then a little bit on HRT as well. Obviously, I could probably talk for about 2 or 3 days, but I will try and keep it brief. So the average age of menopause in the UK is about 51, and that hasn't changed significantly for a very long time. We have some terms we use. So we use premature menopause when someone is under the age of 45. And we use premature ovarian insufficiency, which is POI, for women under the age of 40, and that affects about 1% of the population currently. And that can be caused under the age of 40 for natural reasons, or it can be if you have chemotherapy, radiotherapy, or have ovaries removed. So there's different reasons for having that. So I think my plea on that point would be to say you're never too young for a menopause. So the youngest person we have in our specialist clinic is 16 currently with an early menopause. So we should always keep menopause in our heads when we're thinking about it. The terms we use is perimenopause is the time leading up to when the periods they start to change and you get some symptoms. So you might miss a period, get some hot flushes, night sweats, then it all disappears again and periods come back to being regular. And that can start a good few years before you're actually going to go into the menopause. And then we say someone's postmenopausal when they've not had a period for a year. So no period for a year. Looking back, it's a retrospective thing. Having said that, the symptoms can start in the perimenopause and then go through the postmenopause and beyond. So some people's symptoms will last for 2 years, 3 years, 15 years, 20 years. So the whole range of different times that it can be. And as I've said, menopause can be natural, it can be surgical, or it can be induced with medication or chemotherapy or radiotherapy. If it's surgical, if you go into hospital and have your ovaries removed or you have radiotherapy, it's quite sudden and you get lots of symptoms as a sudden onset. And generally, if it's natural, it can come and go and be a bit more of a lead into the menopause period. Before you know what's going on with the menopause, you need to know what's going on with the menstrual cycle. So essentially in the menopause, we have run out of eggs, so there's no more eggs to come out. So the hormones can't do their job of having ovulation coming. So the lining of the womb gets thinner, and you don't get any periods. But you need to know about the menstrual cycle before we get onto that. How do we diagnose the menopause? So we do that mainly on symptoms. So I'll go over the symptoms in a minute. We do that on age. So anyone over the age of 45 with some irregular bleeding and some menopausal symptoms it can be menopausal. We don't do bloods except for people under the age of 40 generally, or people if we're not quite sure what's going on. And the reason we don't do them is because if we gathered everyone on the call today and did their bloods, they'd all show different levels. If we did them in 3 days' time, they'd show different levels again. So you might get a blood test that says you're definitely not menopausal because your bloods are low and you might have ovulated and your cycle might be working. But you might not have had a period for 6 months before that, and you might have significant hot flushes and night sweats. So the bloods are really not very helpful. So we tend not to do them. We should also always remember contraception, because the rules are that if you're still having periods, once they stop, if you're under the age of 50, you need to use contraception for 2 years. And if you're over 50, it's for 1 year. So it's always important to remember that, because you never know when you're going to have a spontaneous ovulation. So my long list of symptoms, we've got lots of symptoms here, and we divide them into different ones. So vasomotor symptoms, which are the hot flushes and the night sweats, they can be associated with shivering, with an increasing pulse, feeling faint, some nausea, some palpitations as well. Psychological ones, so anxiety, panic attacks, depression, forgetting things, low self-esteem, psychosexual problems, so decreased sex drive, not sleeping very well, tearfulness, etc. And then the bladder and the vagina have both got estrogen receptors. So as the estrogen disappears around the menopause, you can be more prone to having thinner vaginal walls, which can be painful and rub together, cause some bleeding, some pain with sex, more prone to infections as well, and some problems with the bladder. And then also we get other things. So weight gain around the middle, headaches that can be worse if they're related to hormonal changes, joint pains, muscle aches, and changes in the bleeding pattern, skin changes and hair changes as well. And then longer term, an increased risk of lower bone density. And as you go through the menopause, an increased risk of heart disease as well, because estrogen is protective. So what do we need to do? So I think you need to be kind to yourself. Firstly, you're all attending here, so you need to know the symptoms so you can work them out. And there's quite a lot of stuff online, quite a lot of diaries, quite a lot of logs to keep. It's worth keeping this for a few days or even a few weeks to see what your symptoms are, if you've got any triggers, what makes things worse and what makes things better. And look at that in relation to your diet, look at that in relation to your home life, look at that in relation to work as well. And then by keeping a track of things, you can actually see what's happening. Are they coming in a cyclical pattern? Are they coming all over the place? Does nothing make it better? Do you find that if you have a large cappuccino and then get on the tube, you get a lot of hot flushes because you've got the caffeine, you've got the heat, and then you've got the heat of the tube. So once you know if there's some things that trigger, you can look at how you can deal with those. But once you've got a list of your symptoms and you've got them there, then you don't have to put up with these and you should seek help and support. Sometimes it could be quite a fluster when you're not quite sure what's happening and you're not quite sure how to explain them. But if you've got them written down, they're much easier to work through and then to know which ones go together. So we're going to look a little bit at what we can do. So keeping cool is one thing, and it's quite easy to say keeping cool, but it's quite hard sometimes. So some people will keep a facial spritz in the fridge. So some cold water, you can get them in commercial cans as well. When they feel a flush coming, they'll spray that on their chest or their face. A chiller pillow can go under the bed, under your head at night, and that can keep the back of your head cool. Look at natural fibres or bamboo or wicker fibres that soak up if you're having lots of hot flushes with sweats and lots of night sweats. These can be quite useful. Dress in layers. There's nothing worse than being stuck somewhere in a meeting about to present in a very thick jumper, feeling that you're going to have a flush. So lots of layers that you can take on and off easily. Fans if you can have that, and look at ventilation as well. So in general, we suggest keeping the weight down because we know that if you're overweight, then you can have more intense menopause symptoms for some people, but also keeping the weight down is good for the heart, your joints, things like decrease the risk of endometrial cancer and keeping the pelvic floor nice and healthy. Alcohol is quite a trigger for some symptoms for some people, and we know particularly red wine. So some people find that red wine can really bring on a lot of flushes. So keep a look at that. But also alcohol can be quite bad for the heart and the bones and can impact on sleep. So it can not only give you hot flushes and night sweats, but cause problems with sleeping. We suggest limiting caffeine, again, for symptoms and for sleep. A good diet, so decrease the sugars, lots of complex carbohydrates, increase the proteins and decrease the fats. Some people find eating phytoestrogens, so plant estrogens, might help, and that's things like soya, that's things like chickpeas, beans, etc. Some people take omega-3 for the skin, the joints, and for mood. And some people say that salmon is quite good because it's got a form of serotonin in for mood. So some people like to put that into their diet. For your bones, it's really important to keep moving. You do need a good amount of calcium from your diet, and if not from your diet, a supplement. You need some magnesium as well, and you need vitamin D, and you need to keep moving. So weight-bearing exercises, things like walking, is really good for your bones to keep them strong, and really good for your symptoms as well. For sleep hygiene, have a look at what's happening in your bedroom. Make sure that you haven't got your TV, your phone, etc. Try and do some relaxation beforehand, same time, and you can get some really good CBT, so cognitive behavioural therapy apps for that. And then smoking, we know that smoking makes an earlier menopause and makes more severe symptoms and is worse generally for lots of health. So we do tend to say try and stop or reduce smoking if possible. We know that stress can be a problem, and stress can make things worse as well. So if you're getting flustered with a hot flush and night sweats, sometimes it can make it prolonged or make you feel like it's prolonged. So there's a book on the side, Managing Hot Flushes and Night Sweats with CBT, a cognitive behavioural guide. This was designed for women with breast cancer originally that couldn't use hormones, but it is really useful because it gives a 4-week self-help management course for you to look through and try and work out. Try and reflect on what you can control and try and think about your thinking around things. So if you have a hot flash and you think this is awful, everyone's looking at me and it's going to go on forever, the CBT will try and help you think, actually, it's just a hot flash and no one cares and it will pass. So it's trying to get you to think about things better and trying to help with the anxiety that's around menopause. Brain fog as well is something that lots of people complain of. Sometimes if you do something new, if you try and learn something new, such as a language, such as keep doing Sudokus,
Yeah.
crosswords, that can keep your brain active and that can help sometimes with the brain fog that you might get. So don't be afraid of HRT, but there are some alternatives if you don't want to take HRT or want to try something else first. So some herbal supplements may be helpful, but you do need to speak to a pharmacist if you're on other medication. So an example of other medications, if you've got breast cancer, then we don't suggest trying some of the plant estrogens. Try and get one herb that's got, what's in it, so not a complex, not a multi-pack of anything, and try it for 3 months and see if it works. If it doesn't work, then move on to something else. So NICE, when they suggested what works, they suggested CBT worked for hot flushes and night sweats and anxiety to some extent. That black cohosh, which is a herb, worked for hot flushes but wasn't as good as HRT. St. John's worked for hot flushes, but too many interactions with the rest of other medication, so it wasn't suggested or recommended. But phytoestrogens, if you sprinkle a little bit of soya on your yogurt, on your dinner breakfast in the morning, or take soya yogurt, it's not effective very much as a food supplement. You need much larger doses. So a commercial product, so something like red clover, which is a plant phytoestrogen, in a high dose, will be good for hot flushes and night sweats for some people. And then the reviews of acupuncture were mixed. There are other medications that we can prescribe if you can't have HRT, and I've put them up here, but some of them are antidepressants, and we use a very small amount of them for working for hot flushes and night sweats. So all of these will work on hot flushes and night sweats for some people. So from about 30 to 60% of people will find a benefit from them. What they don't do, though, is work on the other things. So none of these work on any vaginal issues, so vaginal dryness. None of them will work particularly well on sex drive. And they won't protect your bones and they won't protect your heart, but they can be useful for some people if you really can't take HRT. And then on to HRT. So hormone replacement therapy is defined by what's in it. So if your womb is there, so if you've still got the womb, then you need to have both estrogen for the symptoms of menopause and progestogen to protect the lining of the womb from estrogen. And that's either given if you're perimenopausal, so still having some periods, given sequentially, so that mimics a menstrual cycle with a bleed every month, or if you have not had a period for a year, then continuously. So you have estrogen and progestogen every single day. If you've had a hysterectomy and had your womb removed, then you can have estrogen only HRT, and that has a different risk of breast cancer, and it's generally thought to be less risk of breast cancer having just estrogen only. And then HRT is defined as well by how it's given, so that's delivery method. And we've got oral, which is a tablet, which is quite convenient to most people and they know how to take those. And we've got transdermal, which is going through the skin. And that's either in the form of a spray, a gel, or a patch. And any combinations of these. So there's multiple different treatments. When you start HRT, we normally say start it for 3 months, see how it is, and then work on if it's any better and look at the side effects. There isn't a one-size prescription fits all, so sometimes it can be a bit of trial and error as to what helps and what works for you, and what works for you might not work for your friend and vice versa. So sometimes it can be changing a couple of times before you get onto the right treatment. It also isn't static, so we can go through, and what you take when you first start taking HRT is not the same as probably what you'll end up with if you continue taking it for 5, 10 years plus. So HRT helps with hot flushes, night sweats, mood changes, vaginal issues. Sometimes you need to use extra vaginal estrogen. Progestins help the lining of the womb, but there's one of them called eutogestane that can help with sleep as well. And we use testosterone primarily for sex drive, mostly for women that have had their ovaries removed. So as I've said, we can use testosterone in addition normally to HRT. We don't tend to give it by itself, and we tend to make sure that you have vaginal estrogen as well, so that it's no point increasing the sex drive if the vagina is really sore and painful. It is an off-license preparation, so there's no licensed product for a woman, and it doesn't work for all people, but it can be something that can be given if needed. So there's a few myths up here that I just put on just before we bring to a close. So HRT causes breast cancer, and I'm going to show a slide in a moment that shows that it increases the risk of breast cancer for some people, but not as much as is reported in the press. Some people think that if that HRT causes blood clots, well, if we give a tablet, it has more of a risk of blood clots, but if we give it in through the skin, then it doesn't. It's not dangerous if it's given to the right person for the right thing. So it's a medication as with everything. And if you read a leaflet in anything, including paracetamol, aspirin, they've all got risks and benefits. So it's not dangerous if it's given to the right person. HRT doesn't cause weight gain. Unfortunately, the menopause causes weight gain. It isn't a contraceptive. So you do need to use additional contraception if you're perimenopausal still. Natural methods are safer. Well, most of the natural stuff products that are around are supplements or marketed as a food supplement. So we don't have a lot of evidence about what they interact with and what they don't and what their risks are. So they may not necessarily be safer, particularly if you're on other medication as well. And you can take HRT for longer than 5 years, which is another myth that is around. So this is a chart that I like that talks about breast cancer. So we're looking at breast cancer for women aged 50 to 59 who have taken HRT for 5 years. And there's 23 cases of breast cancer in the population. If you use HRT, there's an extra 4 cases. But if you just use estrogen only, if you've had a hysterectomy, then there's less 4 cases. But we carry on down. So the pill has an extra 4 cases. Drinking more than 2 units of alcohol a day has an extra 5 cases. Smoking has an extra 3 cases. Being overweight, BMI of over 30 has an extra 24 cases, but if you do some exercise, there's 7 less cases. So I like this chart because it does tend to put the breast cancer risks into perception. Whereas if you only get it from the headlines in the newspapers, it does seem to suggest most of the time that breast cancer is a really high risk. So the disadvantages of HRT would be the breast cancer, which we've discussed, blood clots, which are low and not if you use a patch or the gel. The same with the strokes. Side effects, things like breast tenderness, things like nausea when you first start, and then sometimes the bleeding, which does stop after a little while when you've been on the HRT and does settle down. You can use vaginal treatments, sometimes with normal HRT, sometimes by themselves. So that can be a pessary or a ring or a gel. And you use those every night for 2 weeks, then twice a week after that. Vaginal estrogens have no risk at all and are equivalent to taking 1 day's worth of HRT. So it can be used by virtually everyone. Otherwise, we do have vaginal moisturizers. So Yes is a good example of that. And that helps to moisturize the inside of the vagina, and then using lubricants with sex as well. So that can be oil-based or water-based too. Lots of resources around, but the ones I would suggest is Daisy Network is for women under the age of 40, so that's for the premature ovarian insufficiency patients. Menopause Matters is a website which has got some information on it. Women's Health Concern is got a massive menopause hub on it. If you want an information leaflet on CBT, hair loss, vaginal dryness, complementary therapies, all the leaflets are there, so they're very good to look at. We've got some leaflets on the Royal College of Nursing as well. And the British Menopause Society, although it's for professionals, has got the British Menopause Society TV, and they've got some little videos about menopause and about different things. And that's me done. So I'm for questions now, or after the next talk, I'm not sure.
Well, I have failed. Thank you very, very much. I have to say I failed at the first hurdle because I forgot to tell people how to ask a question. So I'm sure there are questions. And in fact, thank you very much to Siobhan, who has asked one. But for other people who maybe don't know how to ask questions, there's a bar that you should see sort of near the bottom of your screen, which has got a red dot and a timer at the left hand, and the sort of white phone on a red background for the hang up. So on that bar, if you go to the conversation, which is kind of in the middle, you can show the conversation and you'll get a meeting chat on the right hand side of your screen, and right at the bottom there's type a new message. So if you just put a question in there, that would be great, and that's probably the best way to ask a message, because we're kind of all muted. But so thank you very much. So the question is the brain fog permanent, or does it lessen over time? And when is HRT recommended? Is it something that should be looked as a matter of course when experiencing menopause?
Okay, so the brain fog can get better over time. So some people find it's more immediately in the perimenopausal period, and then it does seem to go after that. But for some people, it can be a longer term problem. So it may be that it is a longer term problem for some people. In relation to HRT, I think when you have it, depends on what your symptoms are and if your symptoms are bothering you the most. If you're under 40, I strongly suggest that you need to take HRT if you can, because it does protect your heart and bones. So that's more replacement of what your menstrual cycle would be making. If you're of menopause, if you're sort of late 40s, early 50s, and you're getting some hot flushes and night sweats, but not sure about taking them and think you can manage them or want to try something else first, then there's absolutely no problem with trying other things first and then coming back to HRT. If you're having lots of symptoms, if they're quite severe and they're impacting on your work and your life, social life, etc., then there's no reason why you couldn't start HRT when you first get those symptoms. So I think it is really an individual choice.
Brilliant. Thank you very much. And another question, I've been suffering from severe joint pain since I turned 50. Is this menopause, and what's the best way to alleviate it?
So yes, it can be menopause. So you need to check out that it's not other things as well, because obviously if it is just joint pains by itself, then there are other causes around for it. If it is related to the menopause, then estrogen is in the joints, it's in the collagen. So a trial of some HRT might help to see if it goes. But I would just check if joint pains is the main thing, just to check out that you're not got anything else going on, sort of anything arthritis like or anything like that. But you could try some HRT and see if that works.
Thank you.
Yeah.
Yeah, no, I would reiterate that as a GP as well, definitely. So another comment, thank you very much. That's really helpful. I'm seeing my GP tomorrow about testosterone, sorry, I can't even pronounce it, to help my zero libido. I am already on HRT. What questions should I ask?
So if you're on HRT already, you need to be. Testosterone works better if you're on a patch or a gel, so the transdermal ones. If you're on an oral one, it doesn't work as well, and the oral one can contribute because it does mop up any of your free testosterone as well, so it can contribute to decreased libido. So I would check what HRT you're on. Check about vaginal dryness as well, because as I say, if you've got a really sore, dry vagina, it doesn't matter how much testosterone you're going to get; it's not going to impact on the libido. So check about vaginal dryness, and then it depends as to whether your GP is able to prescribe testosterone. They might need to write to someone like me to say yes, you can have testosterone. Sometimes you need a blood test beforehand, and then you need a blood test at 6 weeks to 3 months afterwards. Testosterone is off license, so we don't have a licensed product, which is why you need to get a specialist to say yes to it normally. And it is a male hormone, and it works for some people, and there are some side effects for some people, and some of those side effects are things like increased hair growth, particularly around the area where you put the gel, sometimes spots and things. So I think it's important to say that you are aware of what the testosterone is, and just to check with your GP that you're on the right HRT to start with, and then go from there.
Lovely, thank you. And maybe related to that, there's a question that's saying, is there a reason why testosterone is not prescribed as a standard?
Yes, because it's not needed by everyone. So if you look at the whole range of menopausal symptoms, so the libido, as I've said, can be due to dry vagina. It can be due to not sleeping. Some people find that their sex drive is down because as soon as they're close to their partner, they have a massive hot flush. So that doesn't tend to do anything for sex drive anyway. So there can be all sorts of reasons around why the sex drive can be down, and it doesn't work for everyone. So we normally, and some people's sex drive, when we put estrogen back in, so just standard HRT can go up as well. So we tend to do things in a stepwise way, and it's not needed for everyone.
Lovely. So I'm just going to take one more question, and then I'll ask Marcia to speak. Is there any reason or a risk to your health if you don't take any menopause medication?
So generally, no. As I said, if you're under 40, then there can be with your bones and your heart. It does protect your bones and your heart even if after 40. But if you have a good, healthy diet, a good, healthy lifestyle, exercise, and you eat well, and you don't have many symptoms that are impacting on you, then no, there's not particularly any risks. Not everyone needs to take it. And some people actively don't want to take it. So yeah, I think it depends on what your lifestyle is like and what your symptoms are like. I think if you're suffering with lots of symptoms and they're affecting your sleep and they're affecting your confidence and you're affecting your work, then obviously that's a different matter. But yeah, it doesn't have to be taken by everyone. And lots of people do manage with diet, lifestyle, herbs, exercise, etc.
Brilliant. Thank you. I'm conscious that there are lots of questions now in the chat box, and thank you for everybody. So there's a question. I have an IUD, but I think I've gone through the menopause. Should I have it removed?
So if it's a copper IUD, it depends when you went through the menopause. So it depends on your age and when your period stopped. If it's a Mirena with hormones on it, if it's in date, you can use that as part of HRT if you want to. So I would say go and see someone and talk to them about it. If it's just for contraception, if your period stopped and you're over 50, you need it in for a year after your period stop, and if you're under 50, it's 2 years. So I think you need to go and speak to someone and just check that you are in the menopause, and just check why you're going to have it removed, because it would be a shame to have it removed if it was a Mirena and then have one put back in for HRT at a later date. So
Thank you. That's really lovely. And there's thank you very much for this wonderful presentation. Read the 5-year myth. Does it mean that there's no increased risk if you have HRT after 5 years? So the person asking the question had Clifem and then Clivance, which worked, but her GP wanted her to come off it after 5 years. So she's now using patches which don't seem so effective.
So there's an increased risk of breast cancer after 5 years of being on HRT from the age of 51, 52 onwards. So there's no defined time that you have to come off. However, there is a lower risk of blood clots with taking the patches or the gel rather than the tablets. So it will depend if you're fit. We have people in clinic who are fit and healthy in their 60s on oral medication. We do try and put people onto patches or gel if we can. But if we can't, then you could go on to a low dose oral. So I would say there are other things as well as patches. So there is gel, which is now just coming back from its shortage, its little breakaway. So there is gel. Some people find that the patches don't stick and they don't absorb through the skin, and other people find that gel's the same. They don't absorb the gel very well. So it's worth going back and speaking to someone. But there is no defined. So the oldest person we've got in clinic that's still taking HRT is 89. So we've got absolutely no defined rules about things. As long as you understand that the longer you take it, there is a slight increased risk of breast cancer, and that if you're on oral, there's an increased risk of strokes and of blood clots. So you have to understand the risks and then balance it up with how you feel.
Great. I don't know, actually, Debbie, can you see the chat?
Yes, I can.
There's a question. I'm really sorry to Regina who's asked the question, but I'm not 100% sure I understand the question. So I'm going to ask you to look at it as well, Debbie. It says, I'm trying to have a baby, but I have polycystic ovarian. And I assume, and I'm sorry if that I'm assuming, but I hope I'm right in saying that that means you have polycystic ovaries. I'm under 40. What shall I do?
So if we're looking at polycystic ovaries and you're trying to have a baby, firstly, you'd have to, are you having periods would be the first question. If you're not having periods and they're not regular periods, then you're not ovulating, so you won't be able to get pregnant at that point. So you need to go and see your GP and then talk to them about what's happening with your periods. And depending on how long you've been trying for and what's happening with your periods, you may get referred to a fertility clinic. Your partner would need to have semen analysis done as well, because we can't always assume that it's the woman that has the problem. And if you have polycystic ovaries, you've normally got lots and lots of small eggs in those ovaries, but they just need a bit of a help to get out. So sometimes you can have some treatments that just help the eggs to come out. So it's worth going to see your GP and talking to them, but keeping a track of your periods so that you go armed with all the information.
Lovely, thank you. And sticking on the polycystic ovaries, Lindy says, I have PCOS, I'm 58 and no sign of the menopause. Should I be concerned?
So not particularly. So we say the average age is 51, 52, but you have massive variation in that. So some people do go on into their late 50s. It's a pain if you've got really heavy periods as well, because a lot of people are waiting for that. So as long as your periods are still regular, that there's no odd bleeding, there's no bleeding in between, and they're not too heavy, then that's fine. And hopefully the menopause will come at some point.